Thank you very much. It's a great honor and pleasure to be here in this beautiful city and hear all the absolutely spectacular presentations. So I'm here to talk about steroid injection and needle aponeurotomy for Dupuytren disease, a long-term follow-up of a randomized controlled trial. This is our conflicts. So the objective of this was to compare retreatment rates and long-term outcomes for patients with Dupuytren disease who previously had needle aponeurotomy combined with a series of triamcinolone injections or steroid, or those who underwent needle aponeurotomy alone as part of a prior randomized controlled trial. We have a previous published study that looked at six months follow-up for this study. And this was a randomized study. It wasn't blinded because I did the measuring, so I knew what patients had and didn't have. There was also no stratification, and all comers could be entered into the study. What we found was that patients who had steroid injection combined with NA had significantly greater improvement in their motion than patients who had NA alone. So the hypothesis of this particular study is that participants who have steroid with their NA will experience less joint contracture and a delay to retreatment relative to NA alone. So, and this is our null hypothesis, just stated another way, that retreatment rate and contracture severity do not differ between the two study groups. So this was a patient-driven study. So our original study was a randomized controlled trial with a set return. And this follow-up study, patients were followed to allow to return up to 18 months. And if they hadn't returned in 18 months, they were contacted. Their extensor deficit was measured. And retreatment was patient-driven, so patients were given options, all of what has been talked about today, but at the time, collagenase was not available, so it was either fasciectomy or repeat NA, and participation ended when patients underwent their second treatment. So our primary outcomes were treatment as well as TAE, extensor deficit. We had 44 out of 47 from our original study. Follow-up period was 7 to 53 months. Somebody at 7 months went on to a secondary treatment. That's why that's so short. Mean extensor deficit significantly higher in NA than steroid patients at 6 months, as previously reported. We found the same held true for patients who followed up to 24 months, but beyond 24 months, there was no statistical difference. So this is just a graphical representation of the of this, and you can see that there's still a statistical difference up to 24 months, and although there is a difference, it's not statistically significant between the two groups beyond that time period with regards to total extension deficit. With regards to retreatment, there was no statistical difference between the two groups. However, the p-value between the two groups was 0.07. If you take the data and use Kaplan-Meier curves, which are a graphical representation of the data, this looks at retreatment, retreated subjects as a percent of time from procedure, and these are the two groups, and this is the steroid group, and you can see that the estimate is when you get to about 48 months, they are very similar. If you use log rank retreatment testing, you find that the, again, non-steroid group tended for retreatment sooner. Over the time period, the initial treatment for 2 or more joints was more likely to require retreatment, and if you were younger, you were more likely to require a retreatment as well. And if our Cox proportional hazard regression showed that, again, baseline age and number of joints was significant. So there was a limitation to this study in that it's patient-driven, and patients decide when they're going to follow up, and sample size drops off with time as any longitudinal studies happens. But our null hypothesis was rejected, and for the short term, at least up to 24 months, there was a statistical difference with steroid-treated NA patients versus not steroid-treated patients. Thank you.